Well, good morning, everybody. I'm very excited to be here. I will also try to keep it a little brief so that I'm not holding you back from lunch too long. I'm doing a little bit of a shift here because I will be talking about ex vivo gene therapy, but it's still a cell product. And it's unlike some of the other therapies that have been discussed previously, this is a regional therapy and we're transplanting directly into the tissue. So I'm going to be talking about a neuroprogenitor cell product that secretes GDNF, and we're using it to treat different types of neurological disorders. So I'm not going to go into a huge overview about all of the different neurodegenerative diseases. I will focus a little bit on ALS, which is where we are in clinical trials at the moment. But some of these disorders are Parkinson's disease, Alzheimer's, as I mentioned, ALS, also retinitis pigmentosa, which is a type of blindness. And a lot of these have something in common that we know about 10, 15, maybe 20% of those are caused by a genetic and hereditary mutation or disorder. And these are very good targets for in vivo gene therapy. That could be shRNA, it could be CRISPR. In the case, Ionis has a product that is antisense therapy, and that's been working very well. However, about 80 to 90% of those are sporadic. We don't know exactly the cause. We don't have a specific target. And these are really great targets for direct cell therapy, or in our case, cell and gene therapy products, combination products. So there's different types of cell products that you can look into. It could be either embryonic, fetal cells, or induced pluripotent stem cells. And these can be differentiated to neuroprogenitor cells that can then be transplanted. These could be transplanted either as neuroprogenitor cells and have them differentiate inside the tissue, or they could also be differentiated prior to transplantation into neurons, oligodendrocytes, or astrocytes. When you're transplanting or trying to replace a neuron, as potentially has been tried for stroke or spinal cord injury in the past, some of these approaches can be quite difficult because you do need the appropriate circuitry and connections to be done. In the case of ALS, you would have to have those cells connect from the spinal cord to the muscle, which is a great distance and becomes complicated. Oligodendrocytes are a little bit less complicated. They're quite practical and can help remyelinate the CNS, particularly for spinal cord injury and multiple sclerosis. We're focusing particularly on astrocytes, which are a very important type of cell in the nervous system. They provide nourishment and support to not only maintain the blood-brain barrier, but also for neurons, particularly motor neurons, which is what we're looking into. So, there's been a lot of research and publications showing the importance of the astrocytes and growth factors separately. We're focusing on GDNF. Now, one of the ways GDNF has been mostly used is by inserting catheters into the brain primarily the striatum for Parkinson's disease, but there's a lot of complications with getting the growth factor, half-life of the growth factor, maintaining stability of the growth factor, and even the catheter that's in place. So if we can transplant cells that secrete this growth factor, GDNF, it can really help to provide a therapy for some of these disorders. Yep, sorry. So in our case, we're focusing on a product. It's a fetal cortical derived cells. These were converted into single cells, and then they aggregate as what we call neurospheres. Then something we do differently than a lot of other groups is we will, instead of dissociating to passage them, we chop them into small spheres. These keep growing, and that's how we expand them. Now, at some point during, we call it passage 27, we make them into single cell suspension again, and then transfect them with a lentivirus to secrete GDNF. This this lentivirus is then removed, so the cells are no longer maintain replicative capabilities. And now we have the combination product. And at the end, once the astrocytes are transplanted, they can provide the nourishment to the motor neurons, secrete the GDNF, and help protect those motor neurons. So we call this product CNS10 NPC GDNF, and we've done a lot of research with the different collaborators and have shown that there's effects and potential in Alzheimer's, stroke, Parkinson's disease, Huntington's disease, and retinitis pigmentosa, and ALS. So we've done IND enabling studies for Parkinson's. We're in the clinic for retinitis pigmentosa and ALS. We did our first trial, which I'll speak on, transplanting the cells into the lumbar spinal cord. We've currently treated 5 patients delivering the cells into the motor cortex, and have treated 11 patients with subretinal delivery for retinitis pigmentosa. So we partnered to get this to a GMP and clinical grade product. We actually worked with City of Hope manufacturing facility, and this is where we were able to manufacture our cells that then we took to the clinic. So just to go back to ALS, ALS is a devastating disease. There's no therapy. It starts with twitching, progressive weakness and loss of motor function, eventually paralysis, and breathing failure. Most patients have a survival of 3 to 5 years. That's the average. So it's really a disease you definitely do not want to have. So as I mentioned, in the 90% of cases that do not have a genetic target, we're really looking at cell products for a potential therapy separate than the traditional medications. As you may know, there's 2 different neurons, in oversimplifying it, in making muscles move. You have one, the upper motor neuron, going from the brain to the spinal cord. Then you have the lower motor neuron going from the spinal cord to the muscle. Both of them are affected in ALS, so we really think that we need to target the spinal cord, the brain, and for spinal cord particularly, we want to be able to target lumbar for the legs, and then cervical for breathing and arm movement. So our central, a little too fast, our central hypothesis is that this can help delay progression or even stop the progression of ALS. So this just shows our 3 different targets, the lumbar, the cervical, spinal cord, and then the motor cortex. We did a lot of preclinical data, studies to show that we are able to protect the motor neurons. We did unique designs where we transplanted the cells into one side of the spinal cord, allowing us to use the other side of the spinal cord as internal control. So as you may know, ALS and a lot of neurodegenerative diseases can be quite variable between patients. So even in our rat model, this is the case. So when we compared our treated side compared to the untreated side, we saw about 2.5 to 5 times more motor neurons than the untreated side. And as you can see in these images, we have a dose response to the graft size and density, as well as the secretion of GDNF on that treated side. I don't have a pointer. Maybe I do. Okay, so you may be able to see these are the motor neurons right here, and they are taking up the GDNF compared to the other side. So we know that the motor neurons take up the GDNF, and the GDNF can be having an effect. So this took us to our first trial. It was a phase 1/2A where we transplanted 18 patients into the lumbar spinal cord. As I mentioned, we had a unique, even in the patients, design where we transplanted only one leg, allowing us to use the other leg as an internal control. So we tested 2 different doses, escalating doses. The first 9 patients received 2 million total cells distributed in 10 sites. And then the second group received 5 million total cells distributed in 10 sites. Because this is an allograft product, we did have to immunosuppress, and we used a similar immunosuppression regimen as solid organ transplants, but different doses. And that included basiliximab at surgery and day 4, as well as tacrolimus and mycophenolate for a year. So our primary outcome measures were safety, but as well, we were looking at strength of the treated leg compared to the untreated leg. We also looked at CMAP and MRI to see density of the muscle and fat content. So our procedure was just to create a laminectomy. We would open dura and then do 10 injections. Based on our preclinical data, we decided to target just above the ventral horn to try not to affect the motor neuron pool too much. And in our preclinical data, we saw that these cells migrated into the ventral horn. So we didn't really feel like we needed to do that, and that would decrease the risk profile. I mentioned that because it becomes important based on some of our findings, but I want to focus primarily on the Atlas, which is really a dynamometer that's attached to a chair. And that chair has arms that are set in place, and we can measure the patients and reliably and consistently measure them at the same position and remove some of the subjectiveness of the handheld dynamometer, because the observer or the person doing the assessments isn't actually pushing against and maybe giving some variable data. But what we saw very interestingly is that on the treated leg, we did have a tendency for that leg to be stronger throughout in the high dose and in the low dose, particularly at 12 months. Now, I do want to point out that it was not statistically significant. We think that this is primarily for 3 reasons. One, we randomized the site of treatment. In a lot of cases, the patients had progressed quite a bit in their leg strength and had already had either a paralyzed foot or very weak, so that gives us some flooring effect. 2, it was a small phase 1 study. We think we need to treat some more patients. And also, we do need to inject a little bit deeper. But we did meet our primary outcome of safety, and we didn't have any important adverse effects related to the therapy. I do want to point out that we did see some pain in the region that we transplanted in the leg. That was treated without any issues with medication for the patients, where it did not subside by itself. But none of the patients saw that as an issue or a barrier to therapy. Unfortunately, most of the patients that have ALS will die, unfortunately. This is not a disease-modifying therapy at the moment. Once we treat larger areas, particularly the breathing, the cervical area for the phrenic, cervical and motor cortex, we feel like we can achieve that. But we do see surviving grafts up to 4 years. And based on IBA1 staining, we do not see inflammation surrounding the graft. So the cells are surviving. They don't seem to be rejecting. We've evaluated 14 of the spinal cords so far for the 18 participants, and they all have cell survival. So we have published this trial. You're welcome to take a look, but the main takeaway from this study is that we did meet the safety outcome. So it takes us to our trial where we are now, targeting the motor cortex. And we decided to do the motor cortex before the cervical just because of the risk profile, targeting the cervical phrenic area and the breathing center. The FDA recommended that we start with motor cortex, with lumbar, just because of the higher risk until we have more data. And we wanted to get this moving for the patients while we were doing our lumbar trial. We're currently doing our studies in the cervical to be able to move to clinical trial. But working with an old postdoc in our lab, Dr. Thompson, we were able to show that transplanting these cells into the motor cortex led to an increased survival and actually delayed onset in the rats in a more important way than we saw in the spinal cord, showing that the motor cortex and the open motor neuron has a very important role in ALS. So that took us to do our IND enabling studies. We did non-human primates to show that there's no effect in the hand region, and that we have cell survival. And why are we targeting the hand? One is we think there's higher potential for benefit and quality of life for patients if they're able to use their hand compared to one leg. If they're able to text longer, if they're able to type, brush their hair, brush their teeth, potentially even if they're in a wheelchair and they're able to control the wheelchair on their own, that can still give them some independence and improve their quality of life. Eventually, we do plan on extending the treated areas. And the other benefit as well is that the hand area, the hand knob, has been characterized very well, and it's very easy to identify. We can use functional MRI to target pre-surgery, and then in the OR, we're also able to use surface electrodes to determine exactly that we're in the right area. So now I'll just do a quick overview. We don't have results, so I won't delve too much in detail, but it's a similar design where we're only treating one side of the motor cortex, just targeting the hand and arm region. Our primary endpoint is also safety, and we're measuring the strength, but also we're doing some of the assessments to test dexterity, which is a 9-hole peg test. And we have 3 groups here because there was an additional risk profile here with the dominant versus non-dominant hand here. Now, it's a little bit confiscated by the fact that in ALS, it doesn't progress first in the dominant and then in the non-dominant. So it is possible that sometimes the patient's non-dominant hand is stronger and the non-dominant hand may be weaker. So we still thought that starting with the non-dominant hand, moving to the higher dose in the non-dominant hand, and then from there moving to the dominant hand made sense from a risk profile. And we also needed to immunosuppress the patients. So this is just a quick overview of how we identify the hand knob area using functional MRI. And then once we've identified the motor neuron, we do injections in that hand knob area on that gyrus. And we're able to do electrode monitoring single cell to see the depth where the motor neuron and layer 5 would be for the injection site. And as I mentioned, we're looking at 9-hole peg test. It's been used more in multiple sclerosis compared to ALS, and there is some difference in dexterity with the left hand versus right hand, but we still think that it's important to get some of those details when we're treating the hand. So we've treated 5 subjects to date. We haven't seen any complications based on the surgery, and patients seem to be tolerating both the surgery and the treatment without any issues. So what are our main take-home messages here is we are able to combine stem cell and growth factor products for neurodegenerative diseases. The nice thing about this is we are able to replace GDNF with some of the other growth factors that may be of interest, such as BDNF or IL-2 or VEGF, depending on what the researcher is interested in. We're able to transplant safely into the spinal cord and the brain. And based on our lumbar trial, there are some hints of potential efficacy, but they need to be studied further to see actual statistical significance. We know that 1 year of immunosuppression is sufficient to see cell survival up to 4 years. We had 2 patients that actually had to stop immunosuppression even as early as 3 months, and we still saw cell survival. So it's possible that we may be able to cut back on some of the length of the treatment. And we do feel that these therapies can help advance some of these regional cell and combination products for not only ALS, but other neurodegenerative diseases. So as everybody knows, getting to a clinical trial and performing a clinical trial takes a huge amount of effort and people. So I can't really go through them to really thank them, but I do want to thank all the patients and their families for participating in the trials. It's a huge ask for them to be involved in any trial, particularly this type of trial. So we definitely wouldn't have the knowledge we have now if it wasn't for them.